Hello, everyone. A very good evening. Myself, Dr. Sourabh Gupta. I'm a nephrologist and a pediatric nephrologist. I will be discussing with you today a very interesting topic, that is hypertension in children. So whenever we think about hypertension, we don't think about children, but still it is an entity, though it is not as common as in adult, but hypertension in children is a very well-known disease, and it needs its own specific management. So whenever we think of hypertension, we think of what exactly is it? Is it important in children? How should we measure it? BPs are high, but there are no symptoms. Does she need treatment? This is the most common complication, most common question you will ask from the parents. Why the child is hypertensive, and how can you actually make a difference? How can you make it better? So we'll be seeing and discussing these questions in the upcoming slide. So we'll start from what exactly is hypertension. It's a condition where there is a pressure in the blood against the walls of the artery is too high. And in adults, we know hypertension is the leading cause of cardiovascular morbidity and mortality, and there is evidence from the hard outcome. So currently the standards is like 130/80 one has to maintain in a adult patient. In children, we don't have these hard outcome of mortality, of cardiovascular morbidity and mortality, but we have normative data which guides us in the evaluation and management of children. So in adults, we know that if blood pressure is high, there is 3 times more likely that the patient might have a death because of heart disease. So we don't have such data in pediatrics. How we define hypertension in pediatrics is by a percentile system. So if there are 20 children and we arrange them with their blood pressure in ascending order. So this is the patient, this is a child with the lowest blood pressure, and this is a child with the highest blood pressure of the same age group. So the 20th one, the child with the highest blood pressure, will be classified as being hypertensive. So hypertension is defined as average systolic blood pressure or diastolic blood pressure that is greater than or equal to 95th centile for that age, sex, and height on 3 or more occasions. So it is dependent upon the gender, the age, and the height, unlike in the adults where there is a standard cutoff. A pre-hypertension, which now is called as by forcible, it was called as pre-hypertension. The American Academy of Pediatrics have changed it as I'm forgetting the word. So it is defined as average systolic blood pressure or diastolic blood pressure levels that are greater than or equal to 90th centile, but it is less than 95th centile. So this is the updated definition by the American Academy of Pediatrics, where anything which is below 90th centile and in more than 13 years, all the adult cutoffs are used. So normal is more than less than 120/80 is normal in more than 13, and less than 90th centile is normal in below 13 years. So the pre-hypertension is elevated blood pressure. So anything between 90th to 95th centile is a elevated blood pressure, which is not classified as hypertension, but is a concern. Stage 1 hypertension is when blood pressure is more than 95th centile till 95th plus 12 mm of Hg. And stage 2 is when the blood pressure is more than 95th centile plus 12 mm of Hg. So 95th centile will be a blood pressure which you will derive, and you will add a 12 mm Hg on it to get a stage 2 hypertension. So this is, we know that what is hypertension in children, how to define it, but is it important? So why do we need to discuss it? So we need to discuss it because blood pressures are actually leading to a lot of impact on child health. They might affect cardiac, CNS, and kidneys in long run. Around 3.5% of children will be labeled as hypertension if evaluated properly. And around 10% might be pre-hypertensive, though that by our definition. So even if the child is asymptomatic and the child is having hypertension, they can have 10 target organ damage. Up to 40% can have left ventricular hypertrophy. And I'm talking about those children who don't have any symptoms. They are hypertensive, they don't have any symptoms, they can have 40% can have left ventricular hypertrophy, which is a marker of a end organ damage. They can have increased carotid intimal medial thickness, which is a marker of early atherosclerosis. Nearly half of the adults actually have, if we track back, they would have had blood pressures more than 90th centile, that is pre-hypertension range, as children. So primary hypertension actually during childhood, it often tracks into adulthood. Around 50% had pre-hypertension in children. So this is when they don't have symptoms. Then also they have a lot of things which are going on, and it will go on for long, because whole life is ahead. This screen is not moving. Okay, so how to detect end organ damage? So in a child who doesn't have any symptoms but is now diagnosed with hypertension, which is actually, is it important to us or not? So we know, because there are target organ damage and we have to evaluate it. The most important thing in target organ damage is left ventricular hypertrophy, and it should be done in all children who are diagnosed to be hypertensive. So as adult cutoff of LV mass of more than 51 gram per, which is standardized to height of 2.7 m 2.7, can be used in children more than 8 years. Or for boys, 115 gram per body surface area or 95 gram per body surface area in girls can also be used. And if hypertension is causing LVH, it's an indication that one should initiate or intensify your treatment, and pharmacological treatment, and not just lifestyle modification. The other markers, they are done if there is clinically indicated, like retinopathy and albuminuria measurement. Unless the pressures have been sustained or they have been rapidly rising, it will not produce much symptoms. And here's the catch: patients will not have any symptoms, they will not come to you, and if not checked, they will just go on and have problems. So symptoms can be neurological, cardiac, renal, and there can be symptoms which are because of the disease which is causing the hypertension, symptoms of the underlying disease. So a child can have a headache, persistent long standing headache. There can be fatigue, there can be blurred vision, there can be nosebleeds, and there can be even picture similar to Bell's palsy, which is paralysis of the one side of the face. And if not controlled, they might end up with hypertensive encephalopathy with unconsciousness, seizure and bleed. They might have heart failure, where they might complaints of extreme tiredness, shortness of breath, palpitations, and swelling of ankle, feet, and stomach. They might lose their appetite. They might have continuous coughing, especially postural lying down. They have rapid weight gain and having frequent urination. They can have kidney problems, which are similar to the cardiac problem, where they have energy loss, dyspnea, loss of appetite, and urinary problem. They might pass less or more urine and swelling. So, so it is important. We know that. So how to measure it? It's not as simple as in adulthood. One has to still, make it a habit to do a blood pressure in a pediatric patient. So every patient who is more than 3-year-old actually should have a blood pressure measured. So though it is not a very routine practice, but it has been emphasized by the fourth report and also by the American Academy of Pediatrics, as well as endorsed by Indian Academy of Pediatrics. So and children who are having complications since birth, like prematurity, low birth weight, congenital heart disease, renal diseases, their blood pressure should be measured even if they are less than 3-year-old. Though it might be difficult, but it can be done over once it becomes a habit. So how to measure a blood pressure in a child? The child should be calm. He should be free of anxiety. Should be sitting quietly for 5 minutes, as in this photograph, and his back should be supported. Feet should be on the floor, right, and preferred is the dominant, non-dominant hand, where one should measure a heart blood pressure at the level of heart. So it should be recorded after a rest of 5 minutes, and consistency one can use arm, same arm in the same patient, but a non-dominant hand should be preferred, and one should put it at a level of heart in the cubital fossa. And one most important thing here is the correct choice of a correct BP curve. So it should be around 80 to 100% of arm circumference in its length to cover the whole arm, and its width should be at least 40%. So the evidence is that it should be around 46-47%, but recommendation have been at least 40%. Previously, we used to say 2/3 of the length between the oligrenone and acromion process, but it has to be measured against the arm circumference and not in the length. So one has to mark the oligrenone and the acromion to get the midpoint, and at this midpoint one should measure the mid arm circumference. So one can have various size of blood pressure cuffs, which can be used according to the age. One should try to measure blood pressure if it is specially documented to be high in all the 4 limbs. The cuff should not be too tight and too loose, and try to take subsequent measurement also in the same limb and same position. There is normally lower limb have relatively higher blood pressure because of the peripheral amplification. This is important that if cuff is too small, try to use a cuff which is next largest cuff, even if it appear large. The reason is because a small cuff will give a very high abnormal value in comparison to a large cuff giving a slightly less value. So this is most commonly happen with pediatric. This is what happened with pediatric patients. So this should not be recorded, or once in a while it will happen. So the reading should be discarded. Also, these practice of using the same gum for the whole family, using a very small cuff, I'm just re-emphasizing them. So this will lead to a very high hypertension documentation in this child. So one should avoid that. So this should be avoided. So what to use, oscillometer or a auscultation method. So till now the evidence is for auscultatory method because it is a better predictor of the target organ damage, and we have normative data which is from the auscultation, and we directly measure systolic and diastolic blood pressure. But oscillometry is coming up with its it's all normative data, and it's easy. It can even be done in infants. It actually calculates MAP, which determine then the SBP and the diastolic blood pressure, and but it overestimates. So one need to have a good normative data from the oscillometer also. So these are the charts you will need to use once you are diagnosing hypertension in child. So you need to know what's the gender of the child, and based on that gender, you have to go to the age. In the age, you have to go to the height of the child, and then in that height, you have to see what is the 95th centile and what is the 95th plus 12th centile. Now, this centile of height, which was previously available, that was the only available thing. But there in the new guide charts, even the height is mentioned. So you have to follow this, because the centiles might be for American children, but may vary for different populations. So this might be a little better approach. So these new charts, they actually have a relatively less cutoff for defining hypertension, and that is probably because the new charts have excluded probably overweight and obese children which were there in the previous data which were published in the 4th report. So here it was relatively higher side. I want to re-emphasize this again, that elevated BP must be confirmed on repeated visits before characterizing a child to have a chronic hypertension. So word is chronic hypertension, and except this should not be done if there is severe hypertension, because it might need urgent treatment. But if it is not severe hypertension, then one should do a repeated visit to make diagnosis of chronic hypertension. It is well known that because of accommodation effect, reduction of anxiety, BP actually tends to fall on subsequent measure, and with mean blood pressure over a time, it will regress to mean. So, but in children, the recommendation for ABPM is coming that it should be done in each and every children, though it's not possible. But here are the reasons why we can do a ABPM, that is ambulatory blood pressure monitoring. Especially in white coat hypertension, where you are getting a high blood pressure in the clinic. It's because the child is apprehensive and actually blood pressures are normal. And if there is you are suspecting that because of the comorbidity there must be hypertension, and you are getting a normal blood pressure, this is called as masked hypertension, and there's a risk of hypertension organ injury, then you can get this ABPM done. If there's apparent drug resistance, that the patient is having drug resistant hypertension, especially 3 or more, the patient is having hypotensive symptoms with treatment, you have to titrate back the drugs. If there is episodic hypertension in every patient of CKD, because they have risk of masked hypertension, and in patients with diabetes and autonomic dysfunction. So what it does, it usually takes a blood pressure for around 24 hours, and the patient do his routine work and sleep. And recordings are taken around every 20 to 30 minutes, and the graph is developed by a software where BP load can be calculated. BP load means how many readings are above the cutoff. So normally there is a dip in the evening, dip in the night. This is the sleep time which has been marked. This has to be marked by us. Then what is the sleeping time of the child? And there's a dip in the evening, it is normal. And if there is non-dipping, that also is abnormal finding. So what is a valid ABPM record? At least 1 reading per hour, including during sleep, and at least 40 to 50 readings in a full 24-hour report. And how will you define that patient is having hypertension in ABPM? The blood pressures are more than 95th centile, because there's a mean BP, not systolic, so 95th centile, and combination of systolic load of 50 to at least 50% of 95% centile over a period of 24 hours. So at least 25% record should be more than 95th centile, and the mean should be more than 95th centile to label as abnormal ABPM and hypertension via ABPM. So how will you then know what exactly a patient is having? So if office BP is normal, you are suspecting mass hypertension. ABPM is also normal, that there is less than 5th to 95th centile all mean BP, and the load is also less than 25%. So you know this is normal. White coat, when the office was high but the ABPM is normal. Pre-hypertension, when blood pressures were in the office was more than 90th centile. The mean BP in ambulatory is actually less than 90th centile, but the load is more than 25%. So, or at least 25%. So this is the definition for pre-hypertension in ABPM. And mask, as we discussed, the office BP is normal, but the ABPM is showing mean is more than 95th centile, and load is also more than 25th. So what is then ambulatory and severe? So ambulatory is when the office and ABPM both suggest hypertension, but the load is not more than 50%. And if the load is more than 50%, then it is severe ambulatory hypertension and high risk of target organ damage. So there are long list. These patients should be evaluated. We already discussed with ABPM. So next question which comes to our mind, we have actually examined, we now know how to measure a blood pressure in a child, what is the data, how to interpret the data, when to go for ABPM. So but we need to know why the child hypertensive, because many a times in children the hypertension is secondary, and we can actually correct it by a specific measure. Before going forward and saying that every hypertension is chronic, because we have seen that hypertension is what we have discussed till now is chronic hypertension, but it can be transient also. So there is a long list, but acute illnesses mostly like acute post-infectious glomerulonephritis, hemolytic uremic syndrome, Hypervolemia in a patient, maybe of a chronic kidney disease patient, can have transient hypertension. Chronic kidney disease itself can cause chronic hypertension also. And then pyelonephritis, then obstructive uropathy, then patient who are having drugs like corticosteroids, then licorice. We'll discuss this. This is basically causing apparent mineralocorticoid excess because of acquired one, because the drug inhibits the enzyme. Then cyclosporin and sirolimus treatment. They can also and then cocaine abuse. Then the neurological causes, they all can be reverted once the offending etiology is reversed. So if it is chronic hypertension, now we need to know what is the cause. So is it primary or is it secondary? Primary mean we don't have a cause, just like adults, most of the adults, and secondary we can actually find the cause and treat it. So mostly primary hypertension happens in a post-pivotal age group. Mostly they can be, they might be obese and have positive family history, and mostly they will be asymptomatic. The children with this essential hypertension usually have blood pressure which is only slightly above 95th centile. While secondary hypertension more in the pre-pivotal age, it's more common. They have severe diastolic hypertension, blunting in the nocturnal dip. Mostly they don't have family history except in a monogenic case, monogenic hypertension, and they are mostly symptomatic. So chronic hypertension, most common organ is renal parenchymal diseases like chronic glomerulonephritis, chronic pyelonephritis, VUR, dysplastic kidney, multicystic kidney, ADPKD, ARPKD, and similar diseases. And then it could be vascular, which could be the coarctation, and then renovascular diseases. In the renovascular, it could be renal vein, renal artery stenosis, or it could be renal vein thrombosis, and the past history of umbilical catheter in the neonate can cause thrombus formation, and again vascular hypertension. And then vasculitis, especially the large vessel vasculitis like Takayasu arteritis, and medium vessel vasculitis like polyarteritis nodosa and Kawasaki disease, mainly polyarteritis nodosa. So they will lead to a vascular hypertension in children. And then endocrine causes like hyperthyroidism, hypoparathyroidism, even hypothyroidism can cause hypertension. Then Cushing syndrome, primary hyperaldo, and then pheochromocytoma, and two variants of congenital adrenal hyperplasia. They might be placed in monogenic one, but there are endocrine causes also, like 11 beta hydroxylase and 17 alpha hydroxylase defect. And then monogenic causes, which can be adrenal or adrenal causes and distal nephron causes, like familial hyperaldo type 1, type 2. Type 1 is also called as glucocorticoid remediable hypertension. And then, as we discussed, CAH, and then glucocorticoid resistance. Then distal nephron, it is all itself defective, like Liddle, where there is defective constitutively active ENaC channel. Gordon syndrome, AME, and hypertension exacerbated by pregnancy. So these are the causes. So once we know that we have to look for a cause, we have to go through a battery of analysis. So we have to ask for any transient hypertension. We have to rule out drugs, any drugs the patient is taking. Is the patient obese? Then the mnemonic for this is like monster, where you can just make a activate your brain to think that why exactly the patient is hypertensive. The neonatal history, BPD, I forgot to mention before. BPD and patient who are having obstructive sleep apneas, they are also at risk of hypertension and should be evaluated for hypertension. And then one should look for the signs and symptoms of the various causes which we have discussed, like weight loss in Pheo, weight gain in Cushing's, and then muscle cramps and weakness, especially in hypokalemia because of hyperaldosteronism or apparent hyperaldosteronism. So one should look for the neurocutaneous markers. For example, if the patient is having CAFE spots, so it might be a neurofibromatosis, then causing ash leaf macule in tuberous sclerosis. Then trends in the family. The family history is important. If the early family history is there, it might be a essential hypertension. It might be a monogenic hypertension, and then one has to look for the history of endocrine and the renal diseases, edema, weight gain, and endocrine causes like moon phases, hirsutism, hypokalemia causing muscle weakness, and one should look for a bruit, especially abdominal bruit and renal bruit, palpable kidneys in ADPKD. So by this, you will make a framework in your mind that what exactly is the cause of hypertension in our patient. So once you document the patient is having hypertension, and you have done a 4-limb BP, and you have ruled, you look for that is there a coarctation now. If there is no gradient, so probably there is no coarctation, and probably there is no large vessel vasculitis. But this still it can be renovascular and other disorders. So abnormal urinalysis analysis, renal functions or renal imaging. So it will mostly rule out a renal parenchymal disease, but not 100%. And then one has to exclude the endocrine causes based on clinical examination, history, and then evaluation, and renovascular hypertension. So large vessel vasculitis can also cause renovascular hypertension without causing any gradient, but they can have Takaisu can have pulseless disease and variation in the blood pressure in the limbs. So renovascular hypertension one has to rule out by doing a 4-limb BP, and then one has to look for a bruit, and then features of hyperaldosteronism in the lab report will help you, and features of asymmetric kidneys will help you in knowing if it is renovascular hypertension. And if they are suspecting, you have to first Doppler, renal Doppler. If it is normal, one can go for, or if it is still suspected, one can go for a conventional or a CT angio, ideally conventional angio, which can clinch the diagnosis. Sometimes it is segmental and not picked by a CT angio. And if all things are ruled out, is one has to either look for a monogenic cause or a essential hypertension. So just this is a busy slide, but just bear with me. So here we have done this, that we have evaluated the identifiable causes of hypertension. We have done a complete blood count, rule out chronic renal diseases. We have done KFT, we have ruled out CKD and all. Hypokalemia we have looked at. So if it is there, then we'll suspect mineralocorticoid excess states, especially also alkalosis for mineralocorticoid excess state. Then ultrasound will look for any scar, anomaly, and discrepancy in the size, which will tell us it's a renovascular or a parenchymal disorder. Not always might need to do a nuclear imaging like DMSC to be sure that scars are there or not, because it never missed in ultrasound. So in essential hypertension, has to do a lipid profile, fasting glucose, and make sure that other metabolic other features of metabolic syndromes are excluded. Polysomnography in a patient who is having obstructive sleep apneas. For target organ damage, everyone should undergo a echocardiogram, and if needed, retinal examination and albuminuria also. ABPM if needed. Then if we are suspecting this to be a either a aldosterone dependent hypertension or a renin dependent hypertension, one might need to do a renin aldosterone ratio. So it should be ideally a ratio of renin aldosterone than just a renin alone. And this we have discussed. Then if there is if it's a steroid mediated hypertension, one should do a steroid level. If it is a catecholamine like FeO, then one should do a plasma and urine catecholamines also. So again, re-emphasizing that renovascular hypertension should be suspected in every children with stage 2 hypertension, which is especially diastolic hypertension. If there is a discrepancy in the kidney size on ultrasound, the patient is having hypokalemia and or metabolic alkalosis. So they might not be always there both two, but any one of them will make you suspect that this might be renovascular. If there is a bruit on physical examination in the epigastrium or the renal angle, and then this suspects renovascular hypertension. So basically, this alkalosis and hypokalemia are secondary to hyperaldosteronism, which is happening because of increased renin. So it is renin-dependent hyperaldosteronism, which is causing renovascular hypertension. These hypokalemia and metabolic alkalosis can also occur in primary hyperaldosteronism or apparent mineralocorticoid axis also. And coming to that, monogenic hypertension should also be suspected once there is earlier onset hypertension, hypokalemia. We have ruled out renovascular and renal parenchymal disorders. Renin is suppressed. So if renin is suppressed, aldosterone is activated on its own, causing hypokalemia and alkalosis. So one should suspect monogenic hypertension or primary hyperaldosteronism also. So how can you make it better? So now we come to the part where we have to, now we know that the patient is having hypertension. We have found the etiology, and now we are treating this patient. So if it is essential hypertension or a primary hypertension, the goal is lifestyle management followed by pharmacological therapy. So lifestyle management includes weight loss, physical activity, correct eating habits, DASH diet, we're discussing, stop smoking and alcohol, especially in adolescents, and then pharmacotherapy. So what is recommended stage-wise is that if it is normal, one has to just encourage healthy diet, sleep, physical activity, and rechecking in each visit if the patient is at risk. Elevated blood pressures, that means more than 90th centile, but below 95th centile. So advice is physical activity and diet management, because when they become adults, they are at risk of hypertension. So mostly they don't need medications unless there is underlying disorders like diabetes, heart failure, chronic kidney disease, or if there is documented LVH. In stage 1 hypertension, and the plan should be that one should manage them with lifestyle modifications. But if they fail, one has to start them on pharmacological therapy. In stage 2 hypertension, everything has to be together. One has to manage them by lifestyle modification as well as initiate therapy. The goal, it used to be 95th centile, but by the American Academy of Pediatrics revised goal by 2017, it is 90th centile. And the reason is that the target organ damage even happens in patients who are hypertensive and they remain in the range of 90th to 95th centile. So those patients who are hypertensive, that is more than 90th centile, and now one has to treat them back below 90th centile to prevent target organ damage. And it has been seen that their LVMI improve with this lower thresholds. So there is a good rationale to treat them below 90th centile. And in CKD patient, there is guideline to suggest that one should treat them by below 50th centile. And a lot of these patients have mass hypertension, and it's difficult to reach this target. It's already difficult to manage hypertension in a chronic kidney disease with, because of the multiple drugs required and polypharmacy. And but the targets are below 50th centile according to recommendation. So lifestyle modifications are mainly physical activity. One has to increase physical activity at least 30 to 60 per minute per session in 3 to 5 days per week. And a DASH diet, that means dietary approach to stop hypertension. It was a study, and this diet has been recommended, which includes more intake of consumption of fruits, vegetables, fibers, non-fat dairy, and reduction of salt intake. So when should one do a pharmacological therapy? So if the patient has failed for at least 6 months of lifestyle changes and continues to be stage 1 hypertension, so one has to do that. If the patient becomes stage 2 hypertension or is higher stage 2 hypertension, but there is no modifiable factor like obesity, so one has to treat that with medication. If patient is having symptomatic hypertension, so in primary hypertension, if there is associated diabetes and if there is target organ damage, so this has to be treated with pharmacological treatment. And also obviously secondary hypertension, all secondary hypertension will need pharmacological therapy. So first line therapy are mostly ACE inhibitors and angiotensin receptor blockers. except if there is if you are highly suspecting that the patient is having bilateral renal artery stenosis, one should avoid them, rule out, and then start. The other first line, especially more than 6 years, is calcium channel blockers, long acting. So short acting nifedipine is probably not recommended, and long acting dihydropyridine channel blockers are recommended, like amlodipine. Then diuretics are second line adjuvant, mainly thiazide diuretics. But if the GFR is low, like below 30, one might need even loop diuretics. Beta blockers are lower down in the list, and similarly alpha blockers because of the adverse metabolic profile. So try to start with a single drug and then escalate the dose. And if required, then probably the patient is tolerating. If there is no side effects, then one can escalate the dose. And once the full dose is reached, one can switch to a second hypertensive, which is not tolerating the increase in dose of a single drug. One can add the second drug even before also. So now we come to the management and treatment of secondary hypertension. So it must focus on the underlying disease. So if somebody is having chronic kidney disease, hyperthyroidism, pheochromocytoma, coarctation of aorta, and renovascular hypertension, so one should look for and treat the cause along with treatment of hypertension to make the hypertension control. We have already discussed this bilateral renovascular disease, and one should avoid ARBs before ruling it out. Just a few cases. I have not covered hypertensive emergencies in this presentation, and they can be covered sometime later. So I'll be discussing few cases. This is a 5-year-old boy. And let's see how we work it up. Now this child present with a GTCS episode without any obvious deficit. He has been normal in development in past, and parents haven't noticed any GTCS in past. The child also has axillary freckles, multiple cafe au lait spots. There is family history, but there is no family history. But this child has these features. When he was evaluated, he was found that he is having severe hypertension in all his forelimbs, and BP was elevated in all the forelimbs above 99 centile. So stage 2 hypertension straight away, and with end organ hypertensive emergency. So there was LVH also. So the target organ damage was already set in, but it was the child was the parents were unaware of it. He didn't have any pulse variability, and there was no bruit. So absence of bruit was there, and pulses were palpable. So it was not most likely there was no coarctation or large vessel vasculitis, and we have find some clinical neurocutaneous markers of neurofibromatosis, and there's hypertension. So one has to rule out renovascular hypertension in this patient. So what we did, we further evaluation showed that he's having now hypertensive retinopathy is there, list nodules are there. His investigation showed that there is alkalosis, metabolic alkalosis, and hypokalemia. There was mild hyponatremia, maybe because of pressure natriuresis. So his renal functions were normal. His urine was just show that he's having 1+ proteinuria. That was again maybe transient. His kidney, right kidney was actually enlarged, and left kidney was actually small. His renin was elevated. So he was having a probably a renin dependent hypertension secondary to a renovascular cause. That was our possibility. So we went ahead and we did a CT angio. We couldn't do a conventional angio, and it showed that there is narrowing at the origin of the renal artery. You might appreciate it here better. There is a narrowing in the renal artery at the origin. So this is the most common site of renal artery stenosis in patients of neurofibromatosis, unlike fibromuscular dysplasia, which happens in the here. This actually happens in Takayasu also, that the narrowing is at the ostia. So this patient was treated with labetalol infusion and was gradually shifted to 3 drugs. Then after stabilization, he underwent a percutaneous transluminal renal angioplasty. Though it is known that it is less successful in patient with neurofibromatosis in comparison to a fibromuscular dysplasia, because fibromuscular dysplasia is a static lesion. It doesn't progress while NF might progress. So, but this child did well, and for now he's having well controlled blood pressure with just a single drug. Enalapril was added and maintaining on it. So moving on to our next case. This was a 7.5-year-old male child. He was symptomatic for last 6 months, and he had symptoms of abdominal pain. It was generalized with moderate to severe intensity and increases after food. That tells us that there is definitely something not normal which is going on. Hypertension, headache was there for last 6 months, and there was no specific features, and he has lost around 6 kg weight in last 6 months. A child who used to weigh 23 kg went to become 17 kg in last 6 months, and he was having very poor appetite. So not very well child. And don't have evaluations done in last 6 months and have developed a lot of weight loss. So something chronic going on which has not been evaluated last 6 months. So he came in ER. He was being managed in OPD basis, but don't have any records. Presented with ER with severe shortness of breath and orthopnea. When it was evaluated in ER, he was having severe hypertension, and he was having he was in respiratory failure because of cardiac failure, and he was put on mechanical ventilation and antihypertensive infusions. So his history was reviewed. He didn't have any history except for what was already mentioned, and all his pulses were palpable, and there was no limb difference, and all limbs showed that BP is elevated, and there was nothing to suggest in his examination that it is it's a thyroid related or a renal related hypertension, at least in clinical examination. But his he was having a heart failure. His ejection fraction was not more than 10 to 15%. So something is going on which is causing hypertensive heart failure. It's a chronic infection, inflammation. Hypertensive children mostly have this much severe hypertension. Children mostly have vascular or parenchymal disorders, and so we need to evaluate for that. So we did his urine routine. It was showing some proteinuria of 1+, and otherwise it was bland. So nothing here. He was having mild anemia, which was microcytic, and renal functions were mildly deranged, but he has come with severe heart failure at that point of time. EF was 10% only. So we did evaluate him for all the vasculitis, and we didn't found anything. He had a CT done outside, which was reported normal. But when we saw the film, there was multiple renal infarcts in bilateral kidneys, hypodense infarcts, and so now it was renal or renovascular. That was clear, but what was the etiology? So we went ahead. So we did a CT angio, and what we found that this child is having multiple microaneurysms in the renal as well as in the mesenteric artery. And there was bilateral renal multiple infarctions, and he also had occlusion of the internal iliac artery. So this was his CT. So you can see these are the large infarcted areas in this kidney as well as this kidney, and there are multiple these beading aneurysms in the mesenteric artery. Here also you can see a large infarct. So he was severely hypertensive because of these infarcts, which were causing high renin release and renin-independent renovascular hypertension. So here also you can see a lot of bleeding is there, and there are infarcts. So what is the diagnosis? our diagnosis was polyarteritis nodosa, though we kept a differential of large vessel vasculitis, catastrophic apella, FMD, cryogenic vasculitis. But given the angiographic finding of aneurysms and severe hypertension, it fulfills our understanding that this is polyarteritis nodosa. He was hepatitis B negative, so it was maybe non-hepatitis B, which can be genetic or idiopathic. So he's being managed. He was managed with 4 antihypertensive drugs, and for polyarteritis nodosa, he received methylpred pulses. He received cyclospamide pulse and lumoxulin heparin, because he also had multiple infarcts in the brain and the internal femoral internal iliac artery. And so it was generalized vasculitis, and the child is still sick and admitted. So coming to our case number 3. So this is a 17-year-old male. He's newly diagnosed to have hypertension. He's severely hypertensive. Blood pressures are 150 by 100. Having hypertensive retinopathy, there's mild proteinuria is there. Findings which were significant, that he is having metabolic alkalosis with the bicarb of 30 and hypokalemia. So it suggests that probably there is aldosterone which is high, or something is causing aldosterone-like symptoms, or renin is causing RAS-dependent hyperaldosteronism. But GFR is, and hence GFR is normal. His 𝐘𝐲𝐻, renal Doppler are normal. So it might be either it is renovascular or renal or hyperaldosteronism secondary to something. His TTKG was 4, which is high for given he is still hypokalemic. So we got his renin level, so they were low. We also got his aldosterone level. So we sent renin aldosterone ratio, and both were low. So, so there is something which is causing aldosterone-like symptoms, but it is not aldosterone. So now we know that this is probably these are the typical monogenic hypertension or low renin hypertension as we know it. So the clue to diagnosis was that he was not responsive to spironolactone, which we gave, and he responded to ENaC blocker trimetrine. So we got a genetic diagnosis for him, and he was Liddle syndrome. So basically, it's a ENaC channel which is there in the distal, which is there in the collecting tubule of the kidney, which is mutated, and it becomes constitutively active. And this constitutively active ENaC channel does not get affected by inhibition of systemic hypertension and does not respond to decrease in aldosterone, and does not is not recycled back into the cell. So constitutively active, so will continue to reabsorb sodium and will cause salt and water dependent hypertension, which will mimic hyperaldosteronism. There are management is ENaC blocker. So there are more cases of patients who are having monogenic hypertension, but probably we will stop it here, and we will end this presentation. Thank you.